Well, thank you so much. We call this kind of a live Davos session, which we've done in past years. So I know that we have some of the live stream audience calling in from Geneva, that stayed in Geneva. And so we want to do this as, you know, kind of the strategic roundtable that we planned. I know some of you have the pre-reads for the case studies in terms of, you know, how we work together. I'd like to, before we even start, give everybody a chance to introduce themselves, because I know that there's those speakers that are joining us via the Zoom that don't know necessarily who's around this roundtable. So if we want to begin with a round of introductions, and then we can move from there. And then over to my co-moderator.
Hi, so I'm Jay Iyer, and I'm really glad that you managed to take time from your busy schedules to join us here, and I hope for a very good discussion. I'm Jay. I lead the Access to Medicine Foundation. We have been for about 15 over years, evaluating pharmaceutical industry's investment into healthcare in low-income countries, including how they work on primary healthcare.
Hi, everyone. I'm Vanessa Carey, the CEO of Cghd Global Health, and we partner with governments in Sub-Saharan Africa to train the needed healthcare workforce to get from the last mile to the facility and to close the gap for integrated primary care.
Hi, everyone. My name is Lwazi Manzi, and I'm the head of Secretariat of the AU COVID-19 Commission. The COVID-19 Commission supports President Ramaphosa in his role as the champion on COVID-19 for the continent. Thank you.
Hi, everyone. My name is Sian Williams. I'm a senior policy advisor at the Wellcome Trust. If you've not come across Wellcome, we're a politically and financially independent charitable foundation based in the UK, really working on supporting science to solve urgent health challenges across the world, and particularly thinking about how we can work with communities who are disproportionately affected by serious health challenges. So this is our interest in the discussion today.
Hi everyone, I'm Gemma. I also work at the Wellcome Trust. I sit in our strategic partnerships team, which is a new team. We've just had a bit of a rejig at Wellcome, but I previously worked in our global policy and advocacy team on access to healthcare.
Hi everyone, really nice to meet you. My name is Rut van Asperen. I'm working for Royal Philips. I used to be part of the Access to Care team, so that's a team within Philips that is really working on new partnerships, new innovations, business models to improve access to care. We as Philips have the purpose to improve the lives of 2.5 billion people by 2030, of which 400 million in underserved communities. And that's really the team that is focused on this specific goal. And I'm currently part of the Global Government and Public Affairs team, and also focused on the strategic partnerships.
Hello, everyone. I'm Nita Madhav. I'm the CEO of MetaBiota. We provide data and analytic tools to assess epidemic risk, and we also provide capacity building in health system strengthening in Cameroon, DRC, and Sierra Leone.
Hi, and I guess I never introduced myself, so before I turn it over to those on the stream, I'm Joanne Manrique. I am the CEO of the Center for Global Health and Development. Over to the live stream.
Yeah, Timmy, would you like to start introducing yourself, and then we can.
Thanks, Jay. Hi, everyone. My name is Temi Giwatubosu. I am the founder and CEO of LifeBank. LifeBank is a medical tech company here in Africa, helping hospitals across 3 countries, Nigeria, Kenya, and Ethiopia, connect to the critical supplies they need and delivering it to them in the right condition and on time. Thank you.
Dr. Asher, you're next.
Brilliant. Thank you very much, everyone. Hello, everyone, wherever you are. I guess it's noon now here in Switzerland. I'm actually tantalizingly close to all of you in Davos. I'm here in Zurich Airport. And it's not a coincidence that the Access to Medicine Foundation is co-hosting this, because I'm actually staying here at the Capsule Hotel, pun intended. No pun intended, I should say. Anyway, I'm the co-founder of Doctors. For those of you who have not had a chance to review your materials, Doctors is a digital health platform that and Independent Practice Association for female healthcare providers globally, that matches their underutilized capacity to the unmet needs of health seekers across the emerging world. Happy to join you from the capsule.
Great, thanks for that. Regina?
Hi, everyone. My name is Regina Namata Kamuga, the Executive of Community Health and Information Network. I'm also the chairperson of the Uganda Alliance of Patient Organizations, working with communities, empowering communities, and unleashing their potential to create quality healthcare in Uganda.
Wonderful. Good to see you, Regina. Jasper?
Good morning. Thank you. Cghd, thanks for the invitation, and very happy to be here with this group of people, like-minded and similarly interested in primary healthcare. From what I hear, I work for Invest International, which is the Dutch national trade organization, and we fund around the health lead, and I specifically look at funding, in line with what Ruud said as well, access to care. So how can we get people on the system, primarily focusing on primary healthcare? And I'll tell more about what we are doing later today.
Great, good to be here. I think we have one more person who joined us at the table.
This one? Oh, it does. Erin Hume, I'm the Director of Philanthropy at the WHO Foundation. I recently was at the Bill and Melinda Gates Foundation on their philanthropic partnerships team.
Great. Well, let's get started. So we've got a number of different case studies to discuss, but what we can do is start talking a little bit about what are some of the key goals that we want to achieve in terms of improving primary healthcare. We're taking obviously a bit of a gender lens into it. And we know already that there's a number of countries that have prioritized primary healthcare. There's the Almaty Declaration. So we've had several years where countries themselves are looking at how to improve primary healthcare and invest in it. Some countries have had a significant step back because of the COVID pandemic and other health disruptions and emergency situations that they've been facing. But I think we've got an interesting mix here of public and private partners. Some of us come also with a number of different cases that we have seen. We're going to keep this a bit of an informal kind of a discussion. So I think just to kick it off, what we could start off with is perhaps to talk a bit about what do we see as key opportunities that we think we might miss or we want to ask questions about in improving primary healthcare and really take a gender lens in it. So, are we seeing already improvements in women empowerment, social entrepreneurship in that role? So who would like to kick it off? I didn't necessarily want to start picking people to start talking. Or I can ask. Yeah.
Actually, if no one volunteers, I might call on someone who I sometimes call on out of the blue. So I think, as Jay was saying, I think that there's interested partnerships here and partnerships that have been executed in the past. And I think if we create a roadmap of the different examples that probably each of you is most familiar with, we could create a model that helps us in terms of how we deploy primary healthcare on the ground. So I know some of the partners here have already invested and done a lot of different years of really experience in this area. So Jasper, I'm going to have you kick us off also because I'm proud to say we have a predominantly female participation around this table, which is quite unusual these days. So as we want to hear from you, and then we are going to kick it off to the rest of our experts here around the table.
Thank you, Joanne. As Jay said, of course, Corona was a setback, and we also see that. I think one of the projects that we have been running since late 2017 was seeing how we can improve primary healthcare in Africa. We specifically, Amref and Philips, together with us, picked one county, Makueni in Kenya, to specifically see whether let's say, the private management of a public primary healthcare mandate would lead to better health outcomes. Now, we've talked about that one before, Joe, and especially looking at it also what we do today through the gender lens. And because there's a very large component of the offering is the focus on health outreach. So health demand, community health workers / volunteers. And what you see with the workers volunteers is that a substantial part is actually women. So there, I mean, Asher, maybe you'll talk about the female medical officers. There's a very specifically large focus on female staff. We did not have a focus on female staff, but of course, the female component is very substantial. So it was in the health outreach, and we also saw it in the, of course, the visitors to the clinic, because it's very primary healthcare is for a very large part is about maternal and child health. So there you also see, and the children usually don't come by themselves. So there we also saw that the female component, if you look at it through a gender lens, was absolutely key. So one of the things we did, we ran a pilot from 2018 to 2020 with 3 facilities covering 20,000 people to specifically look at if the county, together with the private consortium, will look at the quality of care, including, as said, the outreach, the health demand, but also health supply, i.e. improvements to the health facilities themselves, and health financing. So basically the 3 demand, supply, and financing under the, Almaty, what you referred to, Jay, before, universal health coverage, so the National Hospital Insurance Fund that they have in Kenya. So at least there would be financial coverage for those seeking care as well, to see whether the outcomes would be better. And we saw actually quite a substantial improvement. So the skill deliveries doubled, vaccination rates, number of visits, etc., certainly improved substantially. If you then look at the program, the only thing the program did at the end is enable in this case, the Ministry of Health in Cghd County, and then for part of the one sub-county, is to basically provide the care in accordance with their local standards. And that shows you what a gap there is between the local standards and the actual performance that you see for the clinics, the consumables, number of staff, etc., and the referral system. So that was very encouraging. And then based on that, we looked with the county to see how we could roll it out across the county as a whole. So there you go to about 220 clinics. Now, then Corona hit. So all the good intentions that we had received a setback. And one of the things that we also found is that if you really want to provide primary health care with a very large female component, catering for a large female component and being provided by a very large female component, if you would like to get there in this case, Kenya, but I think in most low to medium income countries, we will see the same thing. The cost will rise dramatically. And in this case, it wasn't dramatically necessarily, but it was certainly a doubling of the expenses involved. And in the devolved system in Kenya, the counties basically get a budget allocation every year, and that is it. So for the county, the step was just too large. So we got some viability gap funding in place, but that was not enough. And what we're seeking is specifically looking at the central government also in Nairobi, or potentially another location, to make sure that the government at least has a backstop. Because their concern is now that, hey, because more people are enrolled in the health insurance system, there's more revenue in the system which goes to the county, they can pay the consortium. But the problem in the end is that the county was more skeptical about, or did not want to rely on those additional income as the only source of additional income, and was therefore hesitant to engage. So there was the fiscal limitations of the county were substantial, let's say it that way. So that's where we find ourselves now. So we have a very exciting insight into what it takes to get primary healthcare to the level where it should be. The opportunities it provides, of course, for certainly on maternal and child health, for the population in Kenya, in Makueni, in Cghd West. But then, of course, in the end, we talk about that as a proxy for a large number of countries in Africa and potentially beyond. So it was very exciting.
Thank you, Jasper. And I think as we look at the case study, is there something specific in terms of maybe financing, bridge financing, or something that you would, around the partners, and I specifically looking at some of those in Geneva, I mean, is in terms of the next step, if you were to expand it, or I want to challenge you to really take us a little bit more concrete there in terms of that lesson learned. Yeah.
Yeah, no, thank you, Joanne. So I think if I generalize, if I round the numbers a little bit, so the solution would cost the county about 100 million in 12 years. So that would be the payments under the concession. Now, a substantial part of that is already just part of their annual budget. We have a feasibility gap funding in place for about 25 million. So it really was, let's say, another 25 million where the county would need to rely on the additional income generated from the National Health Hospital Insurance Fund. And for that 25, our take would be the county has to take the risk and basically needs to have a guarantee from someone that if the income from the insurance falls short, that they do not have to close schools or in any other way have to cut back on their ordinary expenses to make sure that they can continue to fund the obligations under the consortium. So it's basically a backstop over a period of about 12 years, or I'm generalizing now, about 25 million euros. And then you talk about getting primary healthcare to the Kenyans at the standards locally applicable to about 1 million people. And I also have to say that for the first model, there's a lot of testing at scale that we first need to do. So doing 20,000 inhabitants with 3 facilities is a lot more manageable, straightforward, etc., than doing it for about 220 facilities. So there is some testing at scale that we also need to do. So I think after the first county, the solution will certainly be cheaper also for rollout in subsequent counties or countries as well.
Great, thanks for that. Regina, I was wondering whether you can chip in and tell us a little bit about your experience, especially in how you've moved also from health outreach to now doing more around the supply components in decentralized primary healthcare.
Yeah, that's an interesting question. Thank you for that. So one of the things, of course, is for us, we talk about public health. Yeah, so in public health, we for Kenya, all the interactions have to be with KEMSA. So there was very close interaction. So few more words about the model. So the way I'm talking way back now. Look at a PPP or a concession agreement is basically that the entity owning the concession will assign basically everything to the party doing the execution. So you really talk about the Amref Philips consortium, in this case, taking care of absolutely everything, employing the staff, doing the facilities, etc. So that's the more traditional model. One basically pays and the other one does everything. So here the county was very specific in the Kenyan context that they wanted to retain all the contacts with the public entities. So I'm talking KEMSA here for consumables, and I'm talking NSIF as the national insurance facility. And also they wanted to make sure that all the facilities were still owned also by the county and that they would continue to employ the medical staff that they were already employing. So if medical staff were added, it would also be employed by the county. If we put an administrative function inside over 5, 10, 15, however many clinics, that will be funded by the consortium. Cleaning will be funded by the consortium, etc. Maintenance, but so they didn't want to end up in a situation that the headlines would be that Macquarie County is privatizing primary healthcare or is selling all their healthcare real estate or anything to that effect. So that's where it was somewhat of a hybrid model. So the county retained the relationship with KEMSA. So we have worked closely with KEMSA, and of course in the pilot, if you do a pilot in 3 facilities out of 220, it is always well stocked, to the detriment, of course, of the surrounding facilities, if need be, to make sure that you can run the pilots you want to run the pilots. But that's, of course, a pilot or a first rollout, what you would want to call it, situation. And so most of the discussion have been had with KEMSA. We have some separate initiatives looking specifically that I'm involved in, specifically looking at the availability of medicine to the wider population, talking about accessibility, affordability, and quality. But that was not as basically here. We did everything through the county and through KEMSA.
Okay, and I think for just for housekeeping purposes, if you have a comment or a question, please, physically put up your hand. We may not be able to see the hand raise for those that are dialing in, so you have to physically put up your hand, and I think we can come to you. So if you've got a comment or a question, just jump in. I think that's it's meant to be interactive. I'm just giving you a minute to see whether anyone's pausing to do that. Okay. Regina, could you tell us a little bit from the Ugandan perspective? You've worked in community outreach for a long time. You're also in the board of patient organizations and running Chain Uganda. You've done a lot of work around outreach. You have a new strategy that is looking to expand access via village outreach. And you've also been involved in supply. Can you tell us a bit about your perspective on this issue? Also, some of the key opportunities that you see. Regina? Yes.
Yeah, thank you very much. Over time, we have concentrated the community outreach, promoting health literacy in communities. And this is based on the fact that the low health literacy in Uganda and patient vulnerabilities in terms of poverty, low literacy, low health literacy, double burden of communicable and non-communicable diseases, all impact access to health. And our system is mainly curative, so we focus a lot on preventive to address the healthcare challenges, which include limited human resource capacity, poor access in terms of affordability, accessibility. So reach to the communities to ensure that we give them knowledge, empower them to be able to, first of all, prevent themselves from getting the diseases, challenges in the health system, but also from the decisions, navigate the healthcare system, seek early diagnosis and be able to navigate the healthcare system. Because many people in the community are not even aware where to get which services. So through our community outreaches, we are able to give them information to be able to access healthcare at the right point. And we mainly work with the community health workers. These community health workers are the first point of contact in the community. They are the community doctors in the community. They are very respected. They associate with the people in the community and they listen to them. So we use these community-owned resources to include the village health team, the religious leaders, the traditional and local leaders, reach the unreached in the community. We also use the outreaches because we know that changing behavior and practice start early in life. People understand that health literacy at an early age, they are able to make informed decisions about their health at an early age, prevent them from, being exposed to self-medication, quality medicine, counterfeit medicine, and other practices that are not good for their health.
Great. Thanks, Regina. I'm trying to see whether there's hands and comments. Vanessa, you've been working in Global Health. You're also engaging private sector in community healthcare and health workers. I assume that you recognize a lot of the comments that have already been made across outreach, supply, the need for financing. You can give us a bit of a perspective on where do you see the key opportunities and challenges that you would like to see resolved with this group here so that we can put that into the roadmap as we're discussing.
Of course, it's a pleasure to join everyone and to meet everybody who's joining virtually. So we focus very much on the intervention of building out the workforce, from connecting the community health worker into the facility, and specifically really where that connection, what that connection can look like, because while community health workers are deeply needed for outreach and they're extraordinary advocates for their patients, if you have a woman who's hemorrhaging, she needs definitive care. And so where the opportunity for us in seeing especially women in the workforce and women's empowerment through health has been both for what we can do for the patient, as well as what we do for the provider and the role the provider can play. And so we've been working in partnership with 4 countries in sub-Saharan Africa to focus on building out the cadre midwives. So if you look at the number of expected deaths in childbirth over the next, by 2030, almost half of those could be prevented just by the scale up of skilled birth attendants. So we're talking about hundreds of millions, about 400 million preventative deaths that could be prevented if we scale up midwives. And so midwives are mostly women. So there's a big piece of job creation for women and formalization of their roles in the workforce. And to give an example, we worked in Uganda in Lira in partnership with Lira University, where we helped them to open the doors of the school for midwifery in the north. And we started in partnership with the school at ground zero. So it took 4 years to graduate the first class. And in 2019, we looked at the outcomes of that class. All 100% are employed. All but one of them have actually remained in Uganda. 87% are actually working in the public sector still. And because when we help empower these women to know how to save lives, they want to stay in the system and keep fighting. We've seen this in Malawi, where we've opened the first ever model midwifery ward. So it's a midwifery-led ward in the country where all care is given by midwives. It's only second in the region. And we're starting to transform both how women receive that care. So women are now traveling hours to deliver in the facility. But we're also helping to create a pathway for showing dignified maternity care. Just to give a very precise story, just reading a story of one of our colleagues who was delivering, a woman had come in from the village. She'd been delivering for over 24 hours and it was her 6th child. The baby was not passing. And so they moved her in, says she came into the facility and they realized what happened, the child was breech. So the original team came in and everyone was sort of really, there's a lot of chaos and people were really trying to, figure out what's going on. And in partnership with the faculty and the team we built, we changed what that birthing experience was. So it became quiet, it became calm, it became championing this woman through a very complicated delivery, and the child was delivered safely. And the rest of the team said they had never experienced actually being part of a delivery like that, but then they started to teach it to others and we saw the cascade of what happened. And so as we're doing this work, 70% of healthcare is provided by women. So our job is to create a pathway to formalization and to build those jobs out and then to tell those stories and to make sure it gets institutionalized at the level of governments. But we can't do this without private sector investment, and it has to be long-term. You have to be thinking about the fact it takes time to see this through, but it is transformative. And so Cghd certainly is looking for support to scale our programs in Sierra Leone, where we're building a national midwifery program in partnership with the government there. We're only in 2 districts now out of 16. We need to be at all 16 for a country that has the highest maternal mortality rate in the world, where 80% of women are delivering in institutions, but they're still dying. That's the lack of the skilled birth attendant or that quality of care. And that's the piece that we can intervene. And I'm incredibly privileged actually to be here with my colleague from the AfriCCC and African Union, where we're thinking about how do we systemically create this and create these opportunities and really build out that narrative. And that is 100% going to rely on large scale private sector and audacious investment to think about how we transform that moment, build those models, study them, learn from them, and create those cases for investment that we can then really galvanize around and show the importance of this for social stability, global health security, economic recovery, job creation. Obviously, I could continue, but I will stop. So thank you for the opportunity to join you on this really important discussion.
Thanks so much, Vanessa. And as some of you know me, I'm going to drill down a little bit on that. And I think a little bit is that by way of background, a little bit of what we do is broker some of these partnerships between the private and public sector and then take them through deployment into some success. So something that I'm going to get a little controversial on is that there is some development finance institutions, you know, as you talked about, that midwife, right? And how they deliver care. And having been a mother of 3 boys who delivered 3 C-sections, I know that if I wasn't, you know, in good medical care, I would not be alive. And so the need of that midwife is such that the midwife should get paid. And I'm assuming in a lot of the programs they are. So some of the models that I think are getting out there as we're looking at what partners are brokering and deploying is models that, yes, they're sustainable, but the development finance corporations and some of the private sector aren't paying the women to actually deploy these services. So I think as you're looking at these partnerships, right, and the work with the private sector, and I know that there are, again, some participants in the audience from Geneva, is that I challenge all of us to, as we're deploying models, make sure that the women are getting paid based on, you know, what Vanessa is saying and the needed role. And then with that, I'd like to turn it over to Lawazi in terms of, oh, there's a hand.
Oh. Just before we turn to Lawazi, I think there's a hand from Asher, if I could. Yeah, Dr. Asher? Yeah, I can see names anymore.
Yeah, sure. So, sorry, I didn't want to interrupt, but given, so Vanessa used the magic words audacious investment, and given that we're in Zurich, Switzerland, I thought I'd take this opportunity, if I may, to offer a business model or a finance model that can take a gender inclusive enterprise from $1 million, let's say seed stage, to $1 billion unicorn stage, and actually take you through that journey as to how that can be done. Because that's essentially what we're doing, if I may. And I'd be happy to share the formula or the playbook as to how we're doing this.
Sure. Yeah. Do you want to? Let's have you go right after we hear from Lawazi, if that's okay.
Yeah, absolutely. No worries. No worries.
Would you like to start? Yeah, go ahead. It's my yes, go ahead.
Thanks very much, colleagues, and thanks to the colleagues in the virtual platform. And as I was listening, I came here to actually listen, but then I was coerced into speaking. But as I'm listening, you've actually triggered some memories of what we did in South Africa. And I think I'm going to first put that forth as a case study, because I think there's some things, and I think it's going to segue into what Asha actually wants to say. And then I'm going to, at the same time, maybe pose some propositions, having learned from our COVID-19 response in South Africa. So let me first put forward the case study. In South Africa, to respond to COVID-19, first thing that happened was that the president mobilized 500 billion rand of reserves into the active fiscus. And of course, a huge portion of that money was then going to go directly into the actual core COVID-19 response, including human resource, with the growth of the human resources. So that was the first aspect. So I think the first thing to say about it is that that was state money, right? The second thing was that then we mobilized the private sector, and you will know very well that that mobilization resulted in the Solidarity Fund, which mobilized, I think it was about to the end, $3 billion as an addition as the private sector's contribution essentially to the fight against COVID-19. And most of that money went to the actual core COVID-19 response. So I'm talking about core COVID-19 response because I just want to focus on the health aspects and not the other socioeconomic, stimulus packages. Now, in terms of human resource development, we then, first of all, identified all the community health workers that we could. And then we also went to the external public works program, which falls under public works or not under health. And we recruited tens of thousands of external public health workers from that program and trained them to become community health workers. And in the end, we had 60,000 community health workers. We then deployed those community health workers in mobile vehicles to go into the communities. And this was particularly helpful because at the same time, that's when we had our hard lockdown. And then those community health workers were deployed across the country to all our 52 districts, and they did 20 million community screening and testings in all of the most vulnerable areas, which was excellent coverage. And in fact, I think this model was actually very commonly cited worldwide, as a good way of deploying primary health services, in response to a health emergency. And we did very, very well. And it allowed us to really pick up the first cases very early, and to survey very well, and we managed that first wave of the pandemic, I think, very, very, very well. What needed to happen for those community health workers to get out there? We needed to get vehicles, right? We needed to get them devices. So everybody talks about technology. What does it mean? It means that you need either a pad, a tablet, or a phone. We needed to develop very quickly an application that was going to interoperate with our labs and other existing digital systems, so that you will know all about that. So that there was good central reporting, and we were able to actually survey in real time. We needed petrol to get them there. So how did that all happen? We had Huawei and Mara phones, which unfortunately collapsed. They donated, I think altogether, they ended up donating about 30,000 devices. And these devices were given to the community health workers, and off they went. Engine came on board with the petrol. And then, of course, part of that 500 billion, we bought a whole lot of PPEs, right? Then next, we needed more nurses, right? So the first thing we did was we looked at the nurses that were still training or that were close to kind of qualifying, and we got them across the line as quickly as possible. We employed every single nurse that we could find. And I think eventually in the end, we ended up adding 16,000 nurses to the workforce that was going to respond to COVID. How did that happen? We had to go to the Minister of Labour and the Minister of Finance, get the money from the Minister of Finance and the Minister of Labour to expedite the employments and give everybody 6-month contracts. And this also had to happen with the 60,000 community healthcare workers that were recruited. Now, what is there to be learned about all of this? First of all, we all know that as we talk about universal health coverage, cannot happen without the state, right? But in Africa, we tend to deploy these wonderful catalytic programs. And then when the catalytic programs come to an end, then the states must pick up, and they can't. And hence the programs come to an end, and then we find that we're going 10 steps backwards again. So ultimately, one always, when supporting states with health workforce development, we must also support the states to be able to sustain this health workforce over the long term. So that's the first aspect. The second aspect is that after 6 months of us employing and paying these health workers, who are obviously, I would say they were 90% women, that were recruited into the response, to the COVID-19 response. The next thing, we found ourselves having protests. I remember this very well. Everywhere we went with the Minister of Health, there was a protest. What were they protesting about? A couple of things. Firstly, they wanted to carry on working. They were having a fantastic, a wonderful time with the communities. The communities were appreciating them. The facilities were appreciating them. And they wanted to carry on working, and they wanted to be employed. But they didn't just want to get a stipend now, they wanted to be employed with full employment benefits, number one. Number two, they wanted to be properly dressed and they wanted to look professional, They were saying that we don't want to wear our little tracksuits and all that. We want proper uniforms, want to be recognized in the community, because first we want to be protected. If you're recognized as a community health worker, you're protected, by the community. Secondly, people then know who you are, and they know where to find you, and they know how to seek, et cetera, et cetera. So they just needed clothes, proper clothes to make them look professional. Thirdly, they wanted to keep these devices and they wanted to keep these apps. And they wanted to be able to actually use these devices and this technology to carry on with the work that they were doing. They didn't want them to be taken away because it was so helpful to them, you know. And then fourth, which it came as a surprise and shouldn't have come as a surprise to me. They also wanted good health care themselves. They didn't have good health care for themselves, you know. So when they got sick, you know, they found that they didn't actually have the healthcare that they needed to, you know, to stay healthy and to carry on doing their work. So all of that needed to be financed. And then that's when we got stuck. We only had a stimulus package which drained our reserves. Now we are stuck. The Minister of Labour is saying that it's going to be difficult to actually properly employ them with full benefits and all of that. The Minister of Finance is saying we don't have money, you know, and what happened next? They went to the unions, and now we're still busy dealing with the unions, and the unions are fighting on their behalf. So all of these things I'm pointing out, you know, as we're thinking about deploying female health workers into primary health care, that they have got, we have to have the foresight to consider all of these aspects down the line and understand that our partnerships must ultimately pursue the kind of financing models that we know work for universal health coverage. And it cannot be, we can no longer afford to only think about short-term catalytic programs. There was one other aspect that I wanted to point out. Oh, yes. One other aspect is insurance for female health workers, right? Not just health insurance, but just life insurance, you know? I remember when I was pregnant with my first child, I didn't want to work. I wanted to spend 6 months with him, you know? So I saved up and all of that, but it wasn't enough. And I forgot that we have UIF, but even if I remembered, it's only a tiny little bit of money. And it occurred to me that why can't I have insurance for, you know, life things, you know, as a woman health worker? Why can't I have insurance for maternity leave, you know, to ensure that I actually have enough money to be able to not work, but then, you know, return to work, you know, having raised my children, you know, having taken care of myself, you know, having my well-being, you know, comprehensively taken care of. Why can't I have insurance for, you know, as a woman? We all know that women are the caretakers. If my mother gets sick and I need to, you know, take off, you know, why can't I have that insurance that, you know, if I need to take off a couple of months to look after my dying mother, you know, et cetera, et cetera. So that was another thing that came out from the workforce, is that we need protections, you know, we need protections and reassurances that if we have to pull ourselves out to take care of community members outside of health service, we will be welcomed back again, you know, and you know, and we'll have the ability to firstly take the time off and then also come back meaningfully. So so I wanted to just put those forth, and then I think I will stop here because I think I should probably take it forward then with the modeling discussion.
Yeah, thank you so much. And I think in terms of what you're saying, I think that those are the points that we really need to drive into that roadmap as, you know, development, finance corporations, other private sector partners are thinking about deploying these partnerships on the ground. In terms of Asher, before you jump in, I want to get more specific in your response in terms of what Lwazi commented. You know, she mentioned insurance, right? And reaching all levels of the socioeconomic pyramid. So in terms of the model that you're deploying, how do you intend to kind of reach different levels of the socioeconomic pyramid? Do you address anything related to insurance?
Thank you. That sounds like a planted question. But thank you for that.
Well, I'm going to challenge you once you answer, like I did Jasper, to get more specific. So go ahead.
So let me give you the answer. So we're building the Kaiser Permanente for emerging markets. Think of it that way. And so Kaiser, like in the US, addresses all segments: low income, the uninsured, the previously uninsured, the ultra poor who are public sector financed, the entrepreneurial working poor that are linked to corporate value chains. For example, factory workers that are supplying denim jeans to Levi's, just to give you one example. Then you have blue collar workers that are linked to distributors and retailers that are linked to massive companies like Coca-Cola, Pepsi, Unilever, Procter & Gamble, just to name a few. All of these, and then we can keep going upstream. So obviously then you have the white collar workers directly working for these companies, and then you can go even further upstream to a model that I'll describe slightly later on, where we leverage the diaspora. It's called a diaspora cross-subsidy model. What's common about all of these models, a couple of things. Number one is that they provide comprehensive healthcare, inpatient, outpatient, and pharmacy, end-to-end, A to Z care. Highly curated, coordinated care, which is coordinated by female healthcare providers, both at the front lines, so female frontline health workers, as well as remotely. So remotely located doctors, therapists, pharmacists, dentists, nutritionists, any licensed female healthcare practitioner who can, excuse me, who could be anywhere in the world globally, because we're connecting them to via the internet. So we have literally healthcare practitioners in Australia, Qatar, Singapore, UK, Canada, Venezuela, US, every European country that you can think of, all providing services into Pakistan, which is actually where we are, and we'll soon be replicating in India. And all of these women have one thing in common: they're licensed to practice in country. So they have a license to practice medicine in Pakistan, which also brings me later on to the diaspora model. So what I actually wanted to take you through is a journey, a 4-step journey of how you get to build a $1 billion purple unicorn, which is basically a social enterprise or impact enterprise, which is gender inclusive. Does anybody know why we call these $1 billion impact enterprises purple unicorns? It's not a trick question. I'm actually curious. I want to see if you actually know, if any of you know.
Because you know.
It's because I know? Is that what you said?
No, I think just assume that no one knows why.
No, so actually you can Google purple unicorns and you'll get some a very accurate explanation of what it is. I did not come up with this term. I just simply regurgitated it. It's basically, these are such rare entities that they are almost mythical. So as you can imagine, if you start thinking about $1 billion companies, you don't typically think of impact or social enterprises. None immediately comes to mind. So let me take you through that journey. And also let me share with you the stakeholders or financiers from the DFIs, governments, foundations, and private sector that are enabling this. I'll first preface this by saying that Vanessa's dad actually enabled a lot of what I'm about to tell you, although she doesn't know it. I don't even think her dad knows it.
I'd like to excuse that you'll probably hear some noise from the live stream audience, but over to the live stream, but we are getting lunch served, so apologies. Some of you want to grab your own snacks, but yes, so apologies if you hear sound.
Perfect, food for thought. So here we go. So Seed Stage. Seed Stage is basically an organization, $1 million in revenue. So when we were at Seed Stage Doctors, we had the following financiers, and I'll just take you through rattle through a list. Philips Foundation, Levi Strauss Foundation, Tommy Hilfiger, PVH, which is a French company, Calvin Klein, Grand Challenges Canada, Unilever, Reckitt, Alibaba, Chinese, Freestand Campina, Impact Insurance Facility in Geneva, which is actually financed by Gates and is actually housed with or close to the WHO, I believe, in Geneva. And who am I also? I forget. Swiss Re, the insurance reinsurance company. So these companies have enabled us to get to basically close to $2 million in revenue. Sorry. Now, how do you get from 2 million to 20 million? So there, we've been engaging partners such as Jasper, actually, Impact International, Invest International, rather, Dutch Impact Fund, as well as corporate venture funds. J&J Venture Fund is an example of this. So mostly corporate venture funds that have that make $5 million to $2 million investments. How do you go from there to $100 million growth stage and then up subsequently to $1 billion? I'm actually going to take you through that journey. So one of the most neglected investor species are the diaspora. So I'm part of the South Asian diaspora. I grew up in the UK. I have lived in the United States for many, many years. I'm part of about 25,000 surgeons or doctors in the US whose average income is probably 500,000 US dollars per year, approximately. Some make more, some make less. I'm just giving you the median. Now, there are 3,000 of us that actually are part of a private investor club made up of non-resident Indians and non-resident Pakistanis, NRPs and NRIs, as they're often referred to, that make a minimum commitment of $50,000 per year and upwards usually of $250,000 per year. So that's $750 million of private equity capital that we commit every single year to, which is actually channeled right now through what's called a real estate investment trust, or REIT. Those investments can be made in healthcare infrastructure. They can be made globally, and our preference is to make them across emerging markets. So my point is that that's a single diaspora entity in a single country that has the ability to deploy $750 million worth of capital every single year. We have already discussed starting off with a $100 million commitment every year in Pakistan and replicating that in India. And where do those investments go? Obviously enhancing digital infrastructure across health systems such as the Al Khan University Hospital System, which many of you know is fairly prevalent, prominent in East Africa, South Asia, etc., as well as then fully digitally integrating frontline primary healthcare into those secondary, tertiary healthcare models. So that's basically.
Sorry, Asher. I just want you to sort of see whether you can make your points a bit shorter, because we want to make sure we hear from everyone.
Oh yeah, sure.
Yeah, no worries.
So to cut a long story short, basically, what I'm saying is don't ignore the role of the diaspora. The diaspora populations, whether they're African, Kenyan, Indian, Pakistani, Filipino, you name it, have very deep pockets in many cases and are actually very committed to giving back, because many people went to medical school for free in their home country and are now bearing the fruits or enjoying the fruits of that in their host country, be it the US or wherever, Canada, UK, blah, blah, blah. So I'm done with that. But basically, I just wanted to take you across that financing journey. In this particular journey, DFC, the US government's Development Finance Corporation, as well as commercial entities, are co-investing with the REIT, with the Real Estate Investment Trust. So that's how we're pulling in US government money and private sector money. So ideally to match or co-match the $750 million that we are ourselves raising from the diaspora. So you can start thinking that you can actually start raising billions of dollars just through this type of finance mechanism. And I'll stop there.
Great, thanks for that. So I think this is a good segue to Temi, if Temi is still actually online. Great, thanks, Temi. So I want to uncover a little bit about the role of social entrepreneurship in decentralizing primary healthcare. Not only from your own experience, but also what you've seen in the regions that you work with. You've also, of course, tapped into venture capital fund, looked at local state money coming in. So Temi, I was wondering whether you could give a bit of your perspective on what would you like to see in your experience a bit, and then also tell us a bit about what would you like to see in the roadmap that we are planning to put forward, because I think we got a number of unique examples of how to do this right. And I don't think everyone has seen a central place for all the examples out there, but we need a lot more financing. We need a lot more visibility of some of the activities that we're doing, and we need a lot more empowering on this. But I wanted to hear your perspective from Nigeria.
Thank you. So I thought I'd grab lunch quickly while I was listening to that. So I had to get off the video for that. But my journey to interesting into audacious financing for the work that we do across Nigeria, Kenya, and Ethiopia started incidentally in Davos in 2019, right before COVID became this global emergency. I was invited to Davos by Credit Suisse in 2020, and basically to have conversations with important people who were interested in funding audacious projects. I was very lucky to speak with MSD for Mothers program, to speak with DFC, the DFI from the United States government, and to really have those conversations. And the conversation was very good, and we got funding from MSD for Mothers, and we're having conversations with DFC as well to basically build a supply chain system to reach the last mile. At the time, so for you to know how audacious this kind of backing and this kind of investment is, at the time we were a very small company in Nigeria. We operated in 3 cities in Nigeria. We had just started a third, and we were not last mile. But we had an idea. We had built a technology system that was scalable, that was profitable, and that has a system that is sustainable. And this was what got people looking at us more seriously. Now, with that investment, we were able to do so much with that. And I think that's what's interesting about, what I call audacious founders or unusual founders. Women, usually living at the last mile. I live in Lagos, Nigeria. Usually doing this often thankless work, and usually very connected to the community where they're working. And when they are able to build something that is scalable, that is sustainable, that has a profit motive, but also has impact at the heart of it, then it becomes a game changer. With that small investment, and this investment was quite small compared to what goes around in the global health community, we were able to expand to 3 countries. We're able to become 24 hours delivering blood and oxygen and PPEs and gloves and vaccines, the works, to the very last one. With a very small investment, expanded to all the regions in Nigeria, are able to deliver right to the last mile, up to Maiduguri, right, Borno State, home to Chibok girls, to the very last mile you can imagine. It was a small investment. And it was an investment that was a hybrid investment. There was DFC participating, Credit Suisse gave something they could. MSD for Mothers, through the Financing for Mom initiative, came and financed Lifebank for 2 years. And we proved our model. We exponentially grew our impact. And for me, I think these are the kind of work that needs to be done to back the women who are doing the work at the last mile. I'm just one example. During the COVID-19 pandemic, as an example of the kind of transformative work people like me do at the last mile, we were the first company, first institution actually, in Nigeria to build a testing facility, COVID-19 testing facility. It was a drive-through and a walk-through. We were able to test up to 15,000 people. And at the time, about 5% of Nigeria's entire testing capacity. We built an oxygen plant and was able to deliver oxygen to every hospital serving COVID-19 patients in Nigeria. We built an asset management system to help countries like Kenya, like Ethiopia, like Nigeria, manage their ventilators, their respirators, and ICU beds, and figure out where they are. So that when patients come in and need these resources, they can easily be sorted to the right place. And for me, I think this is an example, and there are many examples, like women like me, working at the last mile. My friend, I have a friend who runs a company called My Medicine, and she delivers critical medicine to the last mile. And she's been doing this quietly, not well funded, for many years, and really transforming the lives sustainably of the most vulnerable members of our communities. And there are many, many examples like that. What the world needs is to look to the unusual places, to the unusual founders, people who don't look like they can build, large businesses, but they can, because they've built something that matters and that just needs that funding, that needs that financing to scale and to really drive impact. So I just wanted to use Lifebank as an example of that, and use the Financing for Moms initiative as an example of what is possible when we back women. Thank you.
Thank you so much. And I think it's just inspirational. And women around the table. And so we want to take a moment to go around. But before we do that, I'd like to turn it over to Geeta from the WHO Foundation. who I know is in transit, is in Davos, but is joining us via Zoom. And I know Gita has been a dear friend, but has worked in different sort of blended financing, really looking at female health workforce. And as you were saying earlier, you know, a little bit of investment can do so much good. And so we need to really focus on, you know, partners around the table and how do we get to that roadmap with the existing programs, like, you know, the experts that are here. Gita?
Joanne, thank you very much. And I see my colleague, Erin, who leads our philanthropy team, is also at your table. It's a pleasure to be here. I'm the Chief Impact Investment Officer of the WHO Foundation. There are three things that strike me about the conversation that has been had so far. The first of which is what the challenge that you issued, Joanne. At the end of the day, what we're looking at when we talk about female health is be compensated for the work that they do, recognizing that they have expenses.
Sorry, Gita, can you start over a little bit? Because Gita, can you start over? You froze. And
Kill the camera for while she speaks.
Okay, what I might do is perhaps come off the video in case the voice quality improves. Is that better?
It's excellent, thank you.
Okay, so just starting over again, I was just going to say the challenge you started us off with here, Joanne, I think is an important one. Recognizing that female community health workers really deserve to be earning what is essentially a salary for the work that they are doing. And the challenge is when we consider them as entrepreneurs. And the biggest difference between an entrepreneur and an employee is rights. And that speaks to what my sister from South Africa brought up, which is the ability to have protections in the work that they do and for that to be priced into the model itself. So that's an element which I think is going to be really important to think through, because that will right size the assessment of what is the investment, the real investment cost of this model. The second thing I wanted to touch on as well is the expectation of performance as entrepreneurs. And in the case of the decentralization of primary healthcare and doing so with women health workers, we are requiring of them to be building businesses that they carry along with them, which includes all the assets that are necessary, the technology, the disposables, the training, the education, the transportation, the logistics, etc. And in my experience, I feel much of that has, again, not been properly priced into the models themselves. And so there is a continuity of financing, which also needs to be assessed. When we think about the role of the investor at the table here, and when I say investor, I'm increasingly hearing the reference of the work undertaken and the financing provided by philanthropists also as investment. And I think that is the right way to look at it. And so if you look at this as a continuum of financing, through essentially establishment of a business. And to Temi in Nigeria, I've followed your business for a very, very long time. And it is incredible in terms of what you have built and the audacity of the vision, even before the financing could step in. And so how can we as investors and as an investment community really utilize all the financing instruments which are at our disposal? That starts with philanthropic funding, including grant capital, that includes debt-based solutions, including the financing of working capital. It includes equity-based solutions, and that also leads us to solutions including guarantee mechanisms. But there's another thing to also recognize, which is as an entrepreneur, the tenor of the financing is very important. So if we are talking about short-term financing, maybe working capital is a better solution, and we need to be careful as to on what terms that financing is being provided. So I feel like we very easily attribute the word micro enterprises, micro entrepreneurs, but we are still needing to think through what the needs are from a financing perspective in the same way we would for a mid-sized company or a large company. And for that, we need to make that which is often invisible and the brunt of that is borne by these women entrepreneurs, and often can create severe hiccups in the sustainable development of these models, we need to look at this in a different way and say, okay, let us make this less invisible. Let us do a true accounting of what the costs are for this model. Let us understand these points of there is agency that is needed. There is continuity of the service provision. There's a certain amount of upfront investment. We don't think twice when we think about this in the form of an early stage business, right? You have Series A funding, you have Series B funding, Series C, you go into private equity, you have larger scale debt that you can access as you start to build a track record. And to some extent, I think there's some work that we need to do in terms of translating this to be fit for purpose for what we're trying to do here. Because the reality is the cost of care with limited resources and more severely limited resources in some parts of the world than others. Vanessa mentioned the importance of midwives in Malawi. That was how I was born, with a midwife in a very small hospital. And so the appreciation for the work that is undertaken is also recognizing a shift to the type of provision of care we wish to have going forward, as opposed to trying to urgently catch up in what often can be low resource settings.
Thank you, Giza. And I just want to give an opportunity to others around the table. And one of the things you echoed is fit for purpose. And I think as we look at this roadmap going forward, really utilizing the local expertise, the people that have tried to deploy this before are deploying, what does fit for purpose mean, really, in terms of it? But I want others around the table to comment on our discussion.
Thank you. Speaking about investment, I think one of the important things to keep in mind is that the importance of preventive medicine and care, even looking at from the public health standpoint as well. So, a lot of the work that we do is involved in preventive services around HIV and AIDS. We do, we're an implementing partner for PEPFAR programs in Cameroon and DRC. So there's a lot of emphasis there, and trying to get those, get early in the process before things become at a more severe level. And I think this applies both at in the clinical care setting as well as for public health, because we want, there's a lot of talk right now. COVID has really catalyzed a lot of early warning types of programs, detection and data. And I think there's a really strong tie-in with the healthcare workers, community health workers, who are often female. And I think Loazi had a very, very good examples there of how they can be the eyes and ears in the front line of when there is something happening, when epidemic is brewing. Let's find out what's going on in the community and have that feedback into the community there. So recognizing the importance of that, and that this really is an investment, because the amount of money it takes to put in these preventive measures will go a very long way towards keeping down the size of the epidemics, and the cost of taking care of those after they've already gotten very large is much greater. So I think that's another way to think about investment in this context.
Thank you so much. Yeah, wonderful things has been said, I guess, a lot to learn from. I think from the private sector also, I was writing down some notes that I think innovation is really important, but therefore also sustainable business models are important. And it's also really important to reach scale with the certain innovations you create. Therefore, it's really important that every sector or every setting is different. So we cannot make maybe one application or one tool or one innovation that works everywhere. We see that with every pilot we do in every different type of environment. There are a lot of other things we need to address, or we need to take into account to reach that scale and to make that impact at a large scale. So it's really important to design and create, taking into account these different settings. And thereby also prevention, I guess, is indeed really important. If we talk about modern childcare and primary healthcare, that's also the main focus from Philips' perspective. We, for example, look at the antenatal care visits. I also worked in Ghana for a while, and when working there in the hospital, you see also you have a lot of preeclampsia, eclampsia during pregnancy. But to prevent it, you need to do scans and antenatal care visits beforehand. That's also part of prevention. So we are thinking about innovations like Lumify, it's a portable ultrasound. Will it actually indeed work? Do midwives like to work with that? How do you make a business model around it? Do you lease it, for example, to a midwife to give them ownership as well and to give them also more skills in that sense? But in some settings, it's not allowed or because of policies to do the scans as a midwife. So those are all things we are also looking into, like how can we give midwives also more ownership, for example, to go inside the communities and work together as community healthcare workers or with community healthcare workers to reach the patients and work on prevention and antenatal care. Besides that, I also wanted to say that I think a lot has been said about financing, which is not my expertise, but I think we also have been writing about blended financing, and that's also what I really hear coming back. That it's really important maybe to have grants, for example, from donors, that you can have impact investment, that can scale or try pilots, but that in the end also the governments indeed need to increase their buy-in to altogether make it work, to reach that scale and to also make it possible to try out innovations and not only stop with a pilot, but to implement it on large scale and go forward. And scale the impact with that. Would you like to say something?
Hello. Oh, it's on. So interesting to hear from everyone. Thank you so much for sharing your perspectives. As I said at the top, we're coming from Wellcome Trust, and so we're a philanthropic funder, but we sit more at the science, academia, and obviously related to healthcare. So we maybe think more about discovery research, fundamental science behind some health issues, but kind of go into products as well. So I think we've not done a whole lot more at the kind of coalface with health interventions, things in country so much, but we're starting to think about, obviously we connect into it, and we're starting to think about with our new strategy how we can have more impact on the ground. And so I think it's just in the first place really, really helpful for us to listen into these discussions, hear about the things that you're doing and what's working and the things you've learned. So I've just written down a few thoughts from the perspective of a funder, maybe a funder who's not so involved in some of these things right now, which may or may not be interesting to try and reflect in your roadmap. So I'll try and make sense of the things I've written down. Maybe the first thing from, say, a funding perspective is, and how we can kind of come in and support what you're doing is kind of making the case for what you need from us and how we can contribute to the great programs you already have. I think we're very conscious sitting in London that, the people on the ground are the experts. They know what is needed and how to run things. We can obviously bring the financing. There's other aspects we can bring, but it's sort of being clear what you need from the funders. And I think we're trying to do more in terms of long-term financing, which sounds like an interesting thing that people are talking about as being helpful. I suppose as well from our perspective, sitting more at the research end, how we can kind of work down this chain from more the research background science, creating the products into sort of using them on the ground, because this is something we tried to work on, but I don't know how much connectivity there is. We're very clear that when we are working on something where we're developing a product, we have to be thinking about that it's useful for the users, that it has access built in from the start. But actually, do we have the expertise to make that happen? Who do we need to speak to further down the line? I think you were talking about, midwives, the scanning equipment not being appropriate for them. And, if we've created this technology, how can we make sure that it goes all the way down the line? To me, there's a connectivity piece where kind of different funders with different perspectives can support. It's really interesting to hear about the sustainability question as well, because I don't think we've cracked that. It feels like a really hard thing to do. And when we're funding, we think a lot about building capacity and capability that can stay in country. But obviously, like our grants last a certain length of time.
like you were saying, the money runs out eventually, and then you need somebody to step in and keep it going. And something that we work on a lot, which it sounds like you all are as well, is thinking about partnerships and bringing in new people, new perspectives at different points who can kind of keep things going. And so some of our projects, that's the tactic we use. For example, we have an AMR surveillance program that we're running in, I think it's Kenya, Malawi, and I've forgotten the last country. Kenya, Malawi, and Ghana, which is in partnership with Pfizer, but we're making sure it's in partnership with the governments of those countries as we go to make sure that, you know, they're able to pick this up when we sort of start to exit the space. And my last point that I was thinking through was, as a funder as well, we try and bring our expertise and our help when we're working with partners on projects. So is there anything else that you could get from us in working with us on this sort of thing? So we work a lot, say, on trying to help create an enabling environment for research to be used, this connectivity. We also work a lot in advocacy. We have some connections. So I don't know if there's something that you talk a lot about different foundations that you're already working with. What are they bringing to the table? Is there more that you can get from them? Is there more that we can be doing as partners in these projects, more than just, you know, supplying the financing for it? So that was an eclectic list of things that I've been noting down as we've been going. It's been really interesting. I think we're learning a huge amount, but yeah, maybe in your roadmap, thinking about the role of funders and how we can kind of play a part in the bigger picture. Do you want to add another quick thing?
We're doing lots of thinking at Welcome at the moment that we're more than a funder, and what does that mean? So what can we bring? As more than a funder, we don't just want to bring the money to you. We want to bring the convening power, we have these connections. And then one final point is, we have, could you, no?
If you're online, just mute yourself.
This message was left at 30.
Oh, thank you.
The final thing, that's okay. It was just that we're thinking about what can we bring other than money. We've got this more than a funder piece of work happening. So it's what can we bring? We have connections. It's not just money. And then the second thing is, Welcome is very, very lucky to have huge endowment and lots of money, but it's not enough. It's still a drop in the ocean compared to the amount that's needed. And that's why we're thinking about partnerships, and I'm part of the partnerships team. And we're thinking about how do we bring people in, and Welcome likes to think of our money as catalytic, and that we want to bring in others, funders. It's not just us acting on our own. But I realize we're low on time, so I will let her speak.
Great, thanks for that. And so I'm going to have a quick summary of what I think we learned today, but I learned today at least. And then I'm going to hand over to Joanna to tell you about some of the next steps that we have in mind. And you feel free to challenge us, after the meeting and share, sort of your perspectives after. So I'm just going to go through a very quick summary. I think we all appreciate and understand that you can only improve the quality of care if we invest in decentralizing primary healthcare. I think we've covered topics around managing supply, managing demand, managing outreach. We've definitely covered the importance of countries and states to invest and keep investing, especially after catalytic financing has really kind of created a pilot. That has been one of the biggest issues that we've also seen in our data, where private sector will get engaged in a particular program and it will stop after a number of years because there's no one to take over, there's no sustainability inbuilt into the actual system. I think the role of private sector is extremely critical. Thank you for those that brought that up. And private sector is looking to partner up in some of these solutions, but they may not necessarily know how or why or understand how to make the best impact out of this. And of course, they all understand also that you need a sort of a long-term vision on these issues. Switching to different pages. I think we've definitely talked quite a bit on the role of decentralizing healthcare and universal health coverage, how you definitely need to pursue different financing models that are in favor of UHC. We have spoken about how to make sure that insurances also cover the different populations that need care, so that it's not necessarily benefiting only one or two segments of populations. I think, have also spoken quite actively about how community health workers, female entrepreneurs who are developing solutions, have a very strong dedication to this and are interested and willing to really work at the last mile on the last mile challenge. And going back into Joanne's points that our health workers need to be paid fairly, have benefits that are fairly, and that needs to be inbuilt into the investment case and the investment into these models that are working. And Geeta brought in several perspectives that we've recorded on how performance as an entrepreneur, performance in these initiatives needs to be seen in a different way and in a more sustainable way by investors and donors that are at the table, so that we can actually do good too and have a greater impact. So I think I try to summarize it in a nutshell because I knew I was low on time, but I do believe we have a number of good initiatives. Some have been scaled up, some have struggled to get further. A lot is in the maternal health and primary healthcare space, which is important. We couldn't find a central place where a lot of this was even captured. So we tried to kind of put things together. Thank you, Joanne and Joanne's team for putting that together from everywhere. And thank you for all those people who managed to put some text together to share it with us. Many of us are not connected. So I do believe that this is an opportunity to connect and get to know more about each other. We're happy to connect you to other organizations, agencies, whether you're seeking ideas, financing, or partners. I do think that this is a start of a longer conversation and a longer discussion on what are the next opportunities and how do we get there. And I want to hand over to Joanna to tell you a bit more about what she's planning there.
Thank you so much. And thank you for the robust discussion. I feel like this is the beginning to echo Jay's words of where we can go further. And I think, what we propose there, in terms of some of the case studies that we saw coming in, and we know that some of you in the live stream didn't get a chance to yet submit the case studies. So what we propose is bringing back some of the points, and summarizing from the key points, Luwazi, that you raised in terms of that case study. How do we take that? I mean, it's there. You may need what we call bridge financing, which one of the development finance corporations taught me about bridge financing. And what is it specifically, to get very specific on numbers, and can we scale that? And then, I think what we can do as different partners is look at what's been working on the ground, how you're working Cghd Global Health. So what we propose is to look at, the case studies and really reconvene to look at that roadmap of how we get there. Maybe around the International AIDS Society, even maybe that might be too close in Montreal, but really moving us beyond, some of the points and sharing it, maybe using this group, as that resource as we go back and forth. And for those of you as well on Zoom, to try to, hone down what is it that we've learned that we can include in that roadmap in terms of access to primary healthcare. But I want to quickly turn it back to each of you if you have other comments before wrapping up. Anybody else? Okay, so thank you, and we'll be following up with each of you, and thank you to those in the live stream audience, and thanks for joining us. And so we'll also be following up with you on your case studies. Thanks a lot.